I now have the privilege of introducing Dr. Honorine Ward, who is our moderator today. Dr. Ward is professor at Tufts Medical Center, an alumna of CMC batch of 1969, and vice chair for the board of directors at the Vellore CMC Foundation. Honorine.
Thank you, Deepika. I'm delighted to introduce our speaker for this first virtual lecture in the series. Dr. Gagandeep Kang, fondly known as Cherry, as Deepika said, is a professor of microbiology at the Wellcome Trust Research Laboratory in the Division of Gastrointestinal Sciences at CMC Vellore. She received her training in medicine and microbiology at CMC and did postdoctoral training in the UK and US before returning to India to continue her work on enteric infections in children in the communities surrounding Vellore. Cherry Kang is internationally recognized for her work on the development and use of vaccines for diseases like rotavirus infection, cholera, and typhoid, conducting large studies to define burden, test vaccines, and measure their impact. She also studies the consequences of enteric infections and has shown that infections in early life impact future growth and cognitive development. During the COVID-19 pandemic, in addition to research on the virus, she has played a major advisory role in the management of this disease in India and internationally. She has over 400 publications and has received numerous honors and awards, too many to name here. But most notably, she is a fellow of the Royal Society UK and an international member of the US National Academy of Medicine. On a more personal note, Cherry has been a colleague, collaborator, and close friend for almost 30 years, and I am so very proud of all her many achievements. Cherry, thank you so much for taking time out of your very busy schedule, especially since it's close to 9 p.m. in India, to speak to us today. Thank you.
Thanks a lot, Honorine, for the introduction, and it's a pleasure to be here, the opportunity to speak with everyone about CMC's research and its impact. I think it's a little bit difficult to talk about all of CMC's research, but suffice it to say that research in CMC actually started with Ida Scudder. So she wrote about vesicovaginal fistulae in this publication in the Indian Medical Gazette in 1918, 30 years before the foundation was established. And since then, along with the service and the education that CMC has offered, we've also in many ways been leaders in research that is relevant to India. I can't really talk about the last 100 years of research, but what I thought I would do is just walk you through the kinds of resources that we have for clinical research. If we look at our yearbook from last year was a year when we had fewer patients than normal because of the pandemic. It was still a year where you saw about 6,000 patients a day on average in outpatients. You had 1,500 plus inpatients in the main campus alone. There were 90 operations, 30 births, 2,000 radiological tests, 37,000 lab tests happening. And this is in addition to CMC having a community base that provides primary care to about 400,000 people. CMC's labs are the best in the country, and we have other support systems that allow us to do research as well, including the Department of Biostatistics and the Office of the Vice Principal for Research. So I thought I'll give you just 4 examples of non-vaccine research at CMC in the past 4 years and what this has meant for India's health and well-being. a group of researchers in the Department of Community Health published in the Lancet in 2004 that suicides in young people in rural southern India were among the highest in the world. This was information that had not been available to the authorities in India. An understanding of what led to these suicides, what led to how people committed suicide, actually resulted in multiple programs that have been undertaken by researchers at CMC, as well as by the state and by national authorities, to look at what can be done for both mental health and suicide prevention. One of the key features that the researchers found was that unlike what happens in the West, it's very difficult to have any warning signals that young people are going to be committing suicide in India. And the reasons why they commit suicide are also very different. If we look at the next paper, that's from our director, Vikram Matthews, who's been pursuing a large body of work looking at affordable treatment for patients who have acute promyelocytic leukemia. This is something that has led to his group being global leaders in the field and to impacting the management of patients and policy in India. If we look at the next paper, which is neurocysticercosis from Vedantam Rajshekhar, this paper is not just about guidance for India, where Dr. Rajshekhar was one of the first persons to show that if you had a single space-occupying lesion in the brain, it was more likely to be neurocysticercosis than a tumor, and has subsequently built a group that looked at both clinical and laboratory diagnosis of neurocysticercosis. It led to him becoming part of a global group that has developed guidance for diagnosis and treatment of neurocysticercosis, which has been endorsed by the Infectious Disease Society of America, as well as by the neurological professional associations in India. And then in the last paper, we talk about non-communicable disease and the work that Nihal Thomas and others have done to demonstrate that it is possible to use frontline workers in the community to support the control of hypertension in rural India. I could have picked 100 other examples where the research that CMC has done has been relevant for clinical practice and for policy in India. But I restricted myself to these because I wanted to focus for the next few minutes really on the work that has been done in vaccine-related research in India. And when we talk about vaccines and research in India, we have to start with Professor Jacob John, who in very difficult circumstances in the 1970s and 1980s started to produce data that was world leading from Vellore. He was able to show that oral polio vaccination with 3 doses resulted in low antibody responses. He demonstrated that if you increase the number of doses to 5, it did improve antibody responses. The government wasn't willing to listen to him then. He did further studies showing that if you did pulsing of 3 doses, essentially giving everybody in the community vaccine at the same time, that actually decreased cases of polio in the community. And then he ran this incredibly large study starting in 1985 in North Arcot district, which had a population of about 5 million, and demonstrated that inactivated polio vaccine gave better protection than OPV. Not only did he do that, he also established a program called Nadi, a newsletter that was sent out. And the newsletter was based on little postcards that were sent in from healthcare providers that allowed for collation of information across the district for the North Arcot District Health Information System. Now, all of these studies were being done at a time when between 500 and 1,000 children were crippled by polio in India every day. The figure at the bottom shows the numbers of cases that were seen between 1974 and 1994. Now, in 1995, things began to change. The first National Polio Immunization Day was held. It essentially was pulse polio immunization, just as Dr. John had recommended. In 1997, the National Polio Surveillance Project was established by WHO and the Government of India. And the foundational pillars of that program were essentially to increase the number of doses in routine immunization, to use pulse immunization at least twice a year across the country and more frequently in other places, to do micro-planning and identification of key informants who could let the health system know about patients with paralysis. Exactly the things that Dr. John had been doing in the 70s and 80s finally became policy in India in the 1990s. And if you look at what happened to poliovirus cases from 1995 onwards, you can see that there was a reduction in the cases, and we had our last case of wild poliovirus infection in India in 2011. India was declared polio-free in 2013. And following that, Dr. John Vipin Vashisht wrote a commentary about eradicating poliomyelitis, India's journey, which was really Dr. Jacob John's journey as well. Well, with polio, the story doesn't really end there in terms of CMC's research. There was another Dr. Jacob John, who is in the Department of Community Health. And he began to do work trying to understand mucosal immunity and what that meant for transmission within communities and what could be done to address outbreaks of polio. So through a clinical trial that he ran in Vellore, he was able to demonstrate that if you gave an inactivated poliovirus vaccine dose to children who had previously been given oral vaccine, that resulted in a very quick reduction in shedding. This is very useful for the control of outbreaks, and it became WHO policy about 3 months after Jacob's paper on this was published. Now, polio has had a long history, and following the EPI program, the expanded program on immunizations, and the universal immunization program in India, we were in a situation where no new vaccines had been introduced in India since 1986, when the measles vaccine was introduced. So in the early 2000s, the WHO recommended that every country have a national immunization technical advisory group that would help the government make decisions about vaccines. The Indian NTAGI, in which Dr. T. Jacob John played a major role during the initial years, was established in the early 2000s, and the principles by which vaccine decisions were made were laid down. Essentially, you had to demonstrate that there was enough disease in the country to warrant a vaccine. So measure the burden of disease. then you had to be able to show that the vaccines that you had for that disease did work and prevented the illness that contributed to the burden. And then the immunization system had to be strong enough to introduce vaccine. So in the early 2000s, I had begun work on rotaviruses, and group A rotaviruses are the most common cause of dehydrating gastroenteritis in children. Essentially, when you get diarrhea, you lose fluid, and viral gastroenteritis also results in vomiting, which means that children cannot be rehydrated with an oral rehydration solution easily. You have to go for intravenous rehydration. And if you can't start an IV, children can die. So at the time that we started our work, about 500,000 children were dying around the world every year because of rotavirus gastroenteritis. We started to study rotavirus in the community. We were actually looking for figuring out how we could get protection from rotavirus infections. And we did this by recruiting a birth cohort in the Vellore slums. Now, in addition to the lab studies we were doing, we were also able to, through the surveys that we were doing of these children, the follow-up of these children, we were also able to measure how much disease there was in the community. We then also linked with the Indian Council for Medical Research to establish a network that was across the country to measure whether the amount of disease that we were finding was similar or different in different parts of the country. Essentially, through this network, where CMC Vellore was the apex laboratory, we showed that 2 out of every 5 children that were hospitalized for diarrhea at all of these hospitals were hospitalized because of a rotavirus diarrhea. We were able to use all of our data to build an estimate of disease burden. And essentially what this showed was that out of all the 27 million children that were being born in India every year, 1 in 2 children would have a rotavirus diarrhea every year. 1 in 8 children would need to go to an outpatient facility. 1 in 30 children would die, and 1 in 650 children would die of a rotavirus gastroenteritis. So clearly, if there was a vaccine that could prevent this disease, we should be using it. The problem, of course, was that the Western world had vaccines, and when rotavirus vaccines were first introduced in the US, they cost about $200 to immunize a child. Now, that wasn't feasible for India. So we worked with Dr. M.K. Bhan, who was a pediatrician and subsequently the secretary of the Department of Biotechnology, and his group in Delhi, and another group in Pune, a company called Bharat Biotech, on a vaccine that was ultimately called Rotavac. This vaccine was evaluated in the first clinical efficacy trial ever to be done in India. And this vaccine showed about 54% efficacy, essentially saying that we could prevent about half of all of the rotavirus episodes that were happening to our children. More important, this was the first product made in the world that was priced at $1 a dose. So that meant you could immunize a child with 3 doses for $3 instead of $200. The price of the same vaccine is now about 60 cents. So this vaccine, we had shown that it worked. And in 2016, this vaccine began to be introduced into the country. And by December of 2019, there was complete immunization of all children in the country. This vaccine had been available in the private sector since 2008. but for every child in the country to be eligible for the vaccine took until 2019. Now, the work that we were doing for rotavirus and for other diseases out of Vellore led to the WHO recognizing our work and making CMC Vellore a regional reference center for new and underutilized vaccine surveillance. One of the vaccines was obviously rotavirus, but the other vaccine that was slated for introduction into the program, for which there was very little data in India and very little data in the region, was the pneumococcal vaccine. And the WHO Regional Reference Center for Pneumococcal Vaccines was led by Dr. V. Balaji. Balaji had the opportunity to train at Tufts, and that actually led to his interest in antimicrobial resistance, where he is, I can say without a doubt, the leading researcher in India. So Balaji has worked on pneumococcal vaccines, identifying the serotypes that cause pneumonia in young children. He serves as a reference laboratory, and he is part of not just the Indian, but also global surveillance networks related to invasive bacterial diseases. He continues to lead in this area, and most recently, he's been expanding his work to look at genomic surveillance for antimicrobial resistance across a range of pathogens that are important to us. His leadership in this area cannot really be overemphasized because he's got training programs where we have people from all over the country coming to CMC to train with him. Now, coming back to decision-making for vaccines, the pneumococcal vaccine and the rotavirus vaccines have been introduced into the national programs in India. Rotavirus first, but now the pneumococcal vaccine, as of last year, is also available to every child in the country. But there are diseases that are specific to India for which we think more vaccines are needed. And I'd like to do a little segue to talk to you about typhoid. Now, typhoid is a disease that every Indian knows. Everyone knows somebody who has had typhoid, and this is a disease that has been with us for centuries. And leading the work on this, Dr. Jacob John again, supported by Dr. J.P. Mulliel, decided to look at what the burden of typhoid really was. And the reason for doing that was that most policymakers had begun to think that because there were antibiotics in India, there was really no need for a typhoid vaccine. The disease burden had been shown to be high in the early 1990s, but subsequent to that, every study that you looked at showed that the burden of typhoid was coming down. In fact, the state of Delhi had introduced a typhoid vaccine in schools. And as you can see from the news article at the bottom, there were a lot of people in the healthcare profession that said that we don't really need this vaccine. It's not very good, and we don't have sufficient disease. So Jacob set out to measure the burden of typhoid in India, and this is a challenge because typhoid, unlike rotavirus, it's usually easier to be able to find viruses because they are plentiful, but finding bacteria can be harder. So blood culture is the only way that we have of doing a typhoid diagnosis. And if you have antibiotics that are given early in typhoid, that means that your blood culture might not be positive. So you might not detect those cases of typhoid. At the same time that we were starting this, report from Pakistan of emerging antimicrobial resistance of what is now known as an extensively drug-resistant Salmonella typhi. Essentially, all children who got extensively drug-resistant S. typhi had to be admitted in hospital and given IV antibiotics because the oral antibiotics were no longer working. So Jacob set out to measure the incidence of typhoid and how severe typhoid was, and to monitor patterns of antimicrobial use, all of the information that would be required to convince policymakers or ourselves that there really was enough typhoid to deserve a preventive intervention. So he set up this incredibly large study where he had 6,000 children at each of 4 sites, so 24,000 children that were followed at least weekly for 2 years, trying to find out if they had fever, whether it was typhoid or not. In addition to this, he went out into remote areas, including to several mission hospitals, RDT, Duncan Hospital, Lady Willingdon, Makunda, Chinchpada, to measure the burden of typhoid. For this, he had to identify a hospital, figure out who came to that hospital, and from all the hospitalized fevers, figure out what proportion of them were typhoid. So as you can see here, the kinds of populations that were served by all of these hospitals ranged from anywhere from 120,000 to 480,000 individuals who lived in the catchment area of the hospital. Now, by doing these very intensive studies over a period of 2 years, what Jacob was able to show was typhoid fever in the urban areas of Delhi, Kolkata, and Vellore ranged from 500 to almost 1,200 per 100,000 child years. A very high incidence rate is 200 per 100,000 child years. Essentially, it means if you had 100,000 children and you followed them for 2 years, 200 of them would develop typhoid, and WHO would call that very high incidence. In Delhi, it was instead 500. In Kolkata, 588. In Vellore, 1,178. Only Pune, which was a rural site, had a lower incidence. And then if you looked at the hospitals, and these are where you see the severe typhoid, the typhoid that needs to be admitted. And again, you can see that in the urban area of Chandigarh, you're at 742, but between 20 and 127 at the other sites. And this is also a very high rate of hospitalized severe typhoid fever. We used all of this information to think about what different vaccination strategies could look like. So if you see the bar in black, that is what happens if we do nothing. And then the next turquoise bar is if you immunize all children, if you bring the vaccine into urban areas and start immunizing children there. And then the green bar is if you do children in urban and rural areas. And then the subsequent bars are if you do a campaign as well as routine immunization. What you can see from this is that the black line on top is your status quo, and our ability to reduce disease is greatest when you have a school-based and a program for routine immunization for all children. But we have multiple options in between. And the question really is, how quickly do you want to see impact? If we do only routine immunization, then the impact can take 4 to 5 years. If we do a more intensive campaign plus routine immunization, you can see a reduction in typhoid in 1 to 2 years. So where are we now with typhoid? We actually presented all of this data to the National Technical Advisory Group on Immunizations. This vaccine has now been approved for introduction into the Indian National Immunization Program. And India has the vaccines for us to be able to ameliorate this burden of disease. I'd just like to end with studies that we are doing on impact. If we look at where we are with rotavirus vaccines, I told you that introduction started in 2016 and the vaccines went countrywide in 2019. So we established, just like we had done a network for rotavirus surveillance, we established the very first impact assessment study in India, taking the states that had introduced the vaccine early and identifying hospitals within them to try and measure what was happening after the vaccine introduction. So shown here, the solid blue line is the percentage of rotavirus positives coming into the hospital. And you can see that there is a peak in the winter. This reflects what happens with rotavirus. Most viral infections tend to be greater in winter. The orange line shows you when the vaccine was introduced. And what you can see there is as the vaccine coverage goes up, which is the dotted line, the percentage virus positives comes down, and that this is a reduction that is sustained. Our estimate is that this translates to saving 30,000 Indian children's lives every year. It's been a true privilege for us to be able to do this work from start to finish. One of the things that we do as researchers that work in India is think about what our goals are. And currently front and center are the sustainable development goals that we are intended to meet by 2030. That's not likely to happen. But I'd just like to point out that only goal 3 is about good health and well-being. But I actually think that out of all of the goals that we have, about 14 of the goals can be related to health. So for example, if you have children who are immunized, who stay healthy, don't get sick, that means that they become productive future workers. Good workers lead to and strong economies lead to goal 1, which is no poverty. So, I think when we think about what we can do with vaccines, there is just preventing disease is just the start of what vaccines can do. So thank you very much for your attention, and back to you, Honorine.
Thank you so much, Cherry, for taking us on that wonderful journey, starting with Ida Scudder's own research and ending with your own research and taking us through the journey of Dr. Jacob John the first, if I may say so, with polio, and Dr. Jacob John the second with all his wonderful work. And a special shout out to my batchmate, Dr. J.P. Mulyal. Today is Women's Physicians Day in the US, at least, and I think it is so highly appropriate that we have you giving this talk. And again, wonderful to have as our founder, Dr. Ida Scudder, who started research in CMC.